Chapter 22, the Respiratory System, Part 2. So, we're moving on to the bronchi. As you can see, the trachea comes down into the thoracic cavity, and it splits into the right and left main bronchi. And then they continue to split and split and split, forming this kind of tree-like structure found inside the lungs. So the main function of the bronchi is to conduct air between the trachea and the deeper structures in the lung tissue. Again, they are lined with a mucous membrane, so they will be able to help filtering the air, warming the air, keeping it moist. The way it branches, you go from the trachea to the main bronchus. Each lung has one main bronchus going into it. The main bronchus will then split into the lobar bronchi. The lobar bronchi go to each of the lobes of the lung. The lobar bronchi then split into the segmental bronchi. So there are many segmental bronchi in each lung. They will continue to branch out into smaller and smaller bronchi, eventually becoming microscopic bronchioles. And at the end of the conduction zone, you get the terminal bronchioles. And again, bronchioles are all microscopic. So to point out that the main bronchus is the first structure carrying air to enter the lung, either the right lung or the left lung. The main bronchus is very structurally similar to the trachea, 4 layers, the cartilaginous rings. However, as the bronchi branch and become smaller and smaller, the amount of cartilage decreases and the amount of smooth muscle tissue in the bronchi increase, until eventually you get to the microscopic bronchioles. In these structures, there is no cartilage. They are held open by the function of the smooth muscle tissue. So the bronchioles, those microscopic structures, have no cartilage. Instead, they only have smooth muscle tissue. An asthma attack is when the bronchioles start to spasm. Basically, that smooth muscle tissue in the walls of the bronchioles spasms, constricts, reducing airflow through the bronchioles. This is, of course, because there's no cartilage to keep the bronchioles open. Also, at the same time, there's often inflammation that starts to occur in the bronchioles, causing them to expand a little bit from the swelling. And also, mucus production tends to become stimulated, the mucus filling up the airspace. So the end job effect is that the lumen, the open space in the bronchioles, is reduced significantly, sometimes completely, so that no air can pass through the bronchioles. And again, the terminal bronchioles is the end of the conduction zone, the zone that is only transporting air. From here, we go to the respiratory bronchioles. So after the terminal bronchioles, they then branch into the respiratory bronchioles. The respiratory bronchioles then travel through alveolar ducts to the alveoli, these little grape-like structures. And an entire cluster of those grape-like structures is called an alveolar sac. So alveolar sac, lots of alveoli attached, connected to the alveolar ducts that go to the respiratory bronchioles. So the respiratory bronchioles are the first structures that are allowing for gas exchange between the air in the lungs and the bloodstream. So all of these structures are covered with pulmonary capillaries, allowing them to send oxygen into the blood and take carbon dioxide out. Now, when you look at the alveolar ducts and the alveoli, and the walls of these structures is extremely thin. They are simple squamous cells, one layer of cells, super thin. So here is a slide of tissue in the lungs. You can see super thin, lots of airspace compared to the thickness of the walls of the alveoli. The thinness is, of course, important to allow for the gas exchange. So the alveolus, these little grape-like structures, are made up of the simple squamous epithelial cells. They're also called the type 1 alveolar cells. They are covered in the pulmonary capillaries. Also found within an alveolus are alveolar macrophages. These are macrophages that go around engulfing pathogens in the alveoli and also any debris that the macrophage can eliminate. Here again, another view of an alveolus. Here's the pulmonary capillaries. When you take a close-up look of this, you see what is called the respiratory membrane. The respiratory membrane is where the external respiration occurs. This is made up of the wall of the alveolus and the wall of the capillary, so that's 2 cells thick, 2 simple squamous cells, thin cells thick. And this thinness is important to allow oxygen to diffuse into the bloodstream and carbon dioxide to diffuse out of the bloodstream. All right, moving on to the lungs in general. So here is a transverse section of the thoracic cavity. Here's the lung, here's the heart. As you can see, there's this space between the lungs and the rib cage. The space is where you'll find the pleural membrane. It is a serous membrane that surrounds each lung. It has a visceral layer that lies on the surface of the lung and a parietal layer that is adjacent to the structures outside surrounding the lungs. And there's a thin space between the visceral pleura and the parietal pleura, and that is where you find the pleural cavity, and it is where you'll find serous fluid. This fluid is important because it helps to reduce friction as the lungs are constantly expanding and relaxing down to their original size, so that this expansion and relaxation would cause them to rub against the rib cage. That would cause friction, which could damage the lungs, but the pleural membrane with its fluid is able to reduce that friction and reduce the damage. There's a model view of the lungs. We can see that the right lung has a superior lobe, a middle lobe, and an inferior lobe. So the right lung has 3 lobes: superior lobe, middle lobe, inferior lobe. There is a fissure between the superior and middle lobe called the horizontal fissure, and another fissure between the middle lobe and inferior lobe. It's called the oblique fissure. Over on the left lung has a superior lobe and an inferior lobe. So the left lung only has 2 lobes. Between those 2 lobes is an oblique fissure. The left lung also has this little indentation called the cardiac notch. Cardiac notch is there because, as we know, the left side of the heart is larger, and so space has to be made for the larger left side of the lung. Finally, attached to the inferior end of the lungs is the diaphragm. The diaphragm is the skeletal muscle critical for breathing. Smoking. Smoking is bad. Here's an explanation of why. It won't be on the exam. However, long life of smoking or other activities that can damage the lungs can lead to emphysema. Emphysema is where the alveoli have been destroyed, leading to a dramatic decrease in gas exchange. It becomes harder to move oxygen into the bloodstream and carbon dioxide into the lungs. So here we see lovely healthy lung tissue, lots and lots of alveoli. Here's someone with emphysema. You can see a major reduction in the tissues that allow for gas exchange. People with emphysema usually have to go on oxygen, so they spend the rest of their life walking around or whatever with oxygen tanks hooked up to increase the amount of oxygen in the air they breathe in. And it is, of course, always amusing and scary to see people using these oxygen tanks and also smoking. Lung cancer. Lung cancer is the leading cause of death from cancer in the U.S. Lung cancer is very fatal. Most people who are diagnosed with it die within the first year. However, few lucky people can get a lung transplant. This is where lungs from someone who died recently is then put inside of someone who needs the lungs. There's the lungs. Here's someone who's had the surgery, and you can see these massive scars. It looks almost like they got cut in half. Respiration. Respiration, as we know, involves inhalation and exhalation, breathing in and breathing out, which is collectively known as pulmonary ventilation. To breathe in, the air pressure in the lungs needs to be less than the air pressure in the atmosphere. This occurs by the contraction of muscles. When the diaphragm contracts, it pulls down on the lungs, expanding the lungs inferiorly. When the external intercostal muscles between the ribs contract, they pull the rib cage out, stretching the lungs out. This stretching of the lungs will increase their volume. If you increase the volume in the lungs, you decrease the pressure. So expand the lungs, increase their volume. It makes space to allow air to go from the outside, from the atmosphere, into the lungs. Inhalation. Critical muscular contractions involved. Then exhalation is the opposite. With exhalation, we need the pressure in the lungs to be greater than the atmospheric pressure. This occurs by relaxing the diaphragm and the external intercostal muscles. When these muscles relax, the lungs will naturally return to the original size, thereby decreasing the volume of the lungs. If you decrease the volume of the lungs, you increase the pressure in the lungs, and this will cause the air to get squeezed out of the lungs and out into the atmosphere. Note, there is no need for muscular contractions. No muscles are needed to contract to cause exhalation. It just occurs naturally when the external intercostals and the diaphragm muscles relax. Of course, the lungs cannot operate on their own. They need input constantly from the brain, specifically from the respiratory centers in the medulla oblongata and the pons, which, as we know, are parts of the brain stem. So the medulla oblongata controls basic rhythm of breathing. So they are the structures that control the contraction of the diaphragm and the external intercostal muscles, causing it to be a nice, relaxed, calm rhythm that will constantly allow air to come in and out, in and out. The pons, another part of the brainstem, helps to coordinate the transition between inhalation and exhalation. Basically, the job of the pons is to make sure we don't breathe in so deeply we damage the lungs. So the pons prevents us from breathing in so deeply that the lungs get overstretched and damaged. And that is it for this lecture.